So one of the drives that led me to start doing this work is that we still horribly regularly see doctors and nurses and other healthcare professionals who crash and die driving home after night shifts. And when the causes of that are looked into, it's often really difficult to definitively say, but these are often lone driver crashes, and the assumption is that fatigue was probably the key factor.
Hello and welcome to A Doctor's View, a podcast looking at everyday health topics and life through a doctor's eyes. Please note that all opinions are my own and should not replace the advice given to you by your own doctor. I'm Dr Bolivios. Let's begin. Hello everyone, welcome to Doctor's View. I'm Dr Bolivios. To continue with this season's theme of improving our health, I'm going to be discussing sleep this week. Sleep is essential for all of us, and a good sleep cycle is a key part of our health. We can all relate to the effects of lack of sleep, such as feeling grumpy and not working at our best. But did you know that sleep deprivation can also have a profound consequence on our physical health? Up to 1 in 3 of us suffers with poor sleep. From stress, computers, taking work home with us, these are all the things that we often blame for our lack of sleep. However, the cost of these sleepless nights is more than just our bad moods and lacking in focus at work. And regular poor sleep actually puts us at risk of serious medical conditions. And studies have shown that this includes obesity, heart disease, and diabetes, and it even shortens your life expectancy. Sleep can be affected by a number of things, and joining me today to talk about how crucial sleep is to our physical and mental health, and also how shift work can impact junior doctors, is Dr Mike Farquhar. Dr Farquhar, hello.
Hi, nice to meet you.
So could you just tell us a little bit about some of the work you've done within sleep, and also actually your main role within the hospital?
So my name's Mike Farquhar. I'm a consultant in sleep medicine at Evelina London Children's Hospital. So my main job is trying to help children and families who have complex, rare and difficult to treat sleep problems. And we see very much the tip of the iceberg in terms of children with sleep difficulties. Alongside that, though, I have a fairly long-standing commitment to trying to think about sleep and the impacts of sleep deprivation and fatigue for healthcare professionals, which is something I think we don't talk about very much in medical training and undergraduate training, postgraduate training. So for the last 7 years, I've been very much trying to improve education and awareness around that for staff, first of all, and then within systems of what we can do to try and improve the consequences that happen when we know people are fatigued.
Thank you. I just want to ask what the common myths regarding sleep are, because I know there's a lot of articles and a lot of well-being and health things out there regarding sleep.
So there's a lot out there, and one of the reasons there's a lot that is different is that there isn't one single answer for what makes good sleep for that fits everybody. So there's a lot of things that work well for some people but not well for others. Some of the biggest myths are things like, so everybody has this idea that there's a magic number of sleep that you must get. And again, that is something that's very variable. So the only person that knows the right amount of sleep for you really is you. And me picking an arbitrary figure is relatively random. There's a lot of things that become normalized. So one of the biggest myths is kind of the high level ones that get perpetuated by people like Margaret Thatcher, or more recently by Boris Johnson, Donald Trump, that sleep is for the weak, that people who somehow seem to manage on less sleep are somehow stronger and better than those who need sleep. And actually, we would probably suggest that the way that people like Boris Johnson and Donald Trump behaves might well be related to the fact that they are chronically sleep deprived. But yeah, it's something that there's a lot of interest in, but not a lot of knowledge, particularly for healthcare professionals, and that can be a big problem, to be honest.
Yeah, and do you see that a lot within patients? I know it's more the children's side of things, but have you noticed that the different sleep patterns affect their health in different ways?
Oh, absolutely. So, I mean, one of the things that we hold as a core fact, I guess, is that sleep is the foundation of everybody's physical and mental health. If you do not get the right amount of sleep, you are not able to keep functioning as well as you should be. So what sleep is doing for everybody is a bit like the regular maintenance check every night that you would do, so like your car's regular MOT check. Sleep is that regular maintenance check that's making sure everything's working as well as it should be. And when you don't get that, things start to go wrong. Yeah. And to begin with, we can cope, and then we kid ourselves that we're coping better than we are. But once you start to have long-standing sleep deprivation, we know that that then has a cost in terms of long-term physical health, so things like cardiovascular disease, the risk of some types of cancer, the risk of Alzheimer's disease, the risks of mental health disease like anxiety and depression all start to go up if you are chronically sleep deprived.
My next point actually question was going to be about the mental health side of things, because we're seeing a lot more things like depression and mental health problems coming through in the media, and I just wanted to get your opinion on how much sleep could play a part in this.
So I think the relationship between sleep and mental health is complex and it's bidirectional. So we know that if you have conditions like anxiety and depression, then one of the things that often starts to go wrong is that normal regulation of wake and sleep. The quality of sleep starts to become less good. So if you have a mental health diagnosis, you are likely to have sleep symptoms as part of that. The opposite is also true, though, and we know that once people are sleep deprived, their risk of becoming anxious or depressed or developing other mental health problems goes up. And it means that it's very difficult to separate sleep out and say, let's just look at sleep in isolation. When you're thinking about sleep and mental health, you have to look at the whole package. And sleep has to be part of both the preventative strategies, but then also part of the treatment strategies if people do get those types of diagnoses. For anyone, if you miss a single night's sleep or you don't get enough sleep on a single night, you will tend to find that you'll be a bit more short-tempered, a bit more irritable the next day. We know that when we look at things that are phenomenally relevant in terms of the care that we deliver as healthcare professionals, so things like your sense of empathy goes down if you are sleep deprived. And we know what tends to happen in an organisation like the NHS when we lose our empathy. There tend to be very significant consequences. It's something that we put a lot more emphasis on in children and adolescents. So there's a couple of good studies in the last couple of years that demonstrate that if you're looking at all of the protective factors for health and well-being for adolescents in particular, then actually sleep is right at the top of the list. And adolescents are a group who are often sleep deprived for lots of reasons that we do our best to try and help fix.
I was going to go on to the adolescent side of things and actually also the adults as well. Have you noticed there's been an increase in sleep disruption, especially nowadays now that there's more electronic devices? And I don't know how, I know there's been different studies regarding the blue light and LCD screens.
So I think one of the myths that does get perpetuated a little bit is that everybody is a lot more sleep deprived now than they were, say, 100 years ago. And actually, when we objectively look at how much sleep people get today compared to 100 years ago, there's not massive amounts of difference, particularly for children and teenagers. What I think probably has changed a little bit more is the quality of that sleep. And there are lots of things that contribute to that. One of those is that as a society in the last 150, 200 years since we invented electric light, there is a lot more light around at times of the day when historically there wouldn't have been light. And light is one of the factors that most strongly influences that normal regulation of wake and sleep. So the fact that lots of us are now on our iPhones, iPads, whatever, at the end of the day, is likely to be one of the things that affects the quality of the sleep that we then get. And obviously, quantity is one thing, but actually sleep quality is probably more important. And if you get a poor night's sleep, then you have all the consequences the next day. It is always more complex than that. And although you often see the headlines, if everybody just got rid of their phones, everybody would sleep better. Whilst there's a degree of truth in that, it is always a lot more complex than that. And good quality sleep is often about doing really simple things well. And many of us just don't do that these days.
I'm interested to hear what those little things are.
So it's all the really boring things. So we know that for everybody that you are most likely to get good quality sleep if you have a consistent sleep routine that's the same from night to night. So that means aiming to go to bed at the same time every night. And crucially, actually, probably even more importantly, is aiming to get up at the same time every day. That's one of the things that once we start thinking about people working in organisations like the NHS becomes more challenging. It's much more difficult to keep a regular sleep schedule if your shift schedule is not regular. For everybody, being able to relax and wind down in that hour before bed is really important. So you don't have to have a diagnosis of anxiety for a stressful day to impact on your sleep quality. One of the examples I often use with parents in clinic is that, if you rock home and discover a scary brown envelope from the taxman saying that you owe a hugely unexpected sum of money, then you don't sleep well that night. So what we do in the daytime can have a big impact on the quality of sleep at nighttime, which means we all need to be good at relaxing and winding down. And actually, that is something that lots of people find challenging. Other really basic, simple stuff. Light is good in the daytime, as much natural light exposure as we can get. So we're sitting recording this on a very grey day in London, but actually even on a day like today, the outside light is brighter than what many of us will be experiencing in inside office or hospital environments. And that lack of natural daylight in many of our lives can have a big impact on the regulation of wake and sleep. So getting as much natural bright light exposure as possible, particularly early in the day, is really helpful for trying to keep our wake sleep as good as possible. Exercise, very boring, normal doctor thing. The more exercise you do, the healthier you are. But actually, the more exercise you do, the better quality sleep you are likely to get. And for most adults with sleep difficulties, increasing or thinking about the exercise you get in the daytime is probably going to be more effective for improving your sleep than getting a sleeping tablet prescription. Lots of sleep is about that, but those are really the key things. It's about consistency, routine, doing the simple basic things and avoiding the things that are bad for sleep. So as well as electronic lights, many of us use caffeine as a way to try and manage fatigue and tiredness. And whilst it has a short-term role in helping to do that, it has a longer-term consequence on sleep quality. And then the other things, so other drugs or substances that can affect sleep. So nicotine can do that. Some medications will. So it's all ties together. And the more of those basic things you get right, the better quality sleep you're going to get.
Mm-hmm. And how do you advise adolescents and children, or advise the parents? What advice do you give to them for these things? Because obviously it's slightly different from a child's perspective in terms of they're probably getting natural light more so than, say, office workers and
you'd be surprised, to be honest. It depends on the individual. So one of the joys of pediatrics is that there is a huge physiological and psychological difference between a 2-month-old infant and a 17-year-old teenager. So it has to be very much tailored to the individual, both in terms of the natural changes in the physiology of sleep that we see at different ages, but then also because we see very much the tip of the iceberg, lots of the children and teenagers that come through our clinic also have other medical problems, so those have to be taken into account. But actually, even for the most complex, it's about finding ways to get that basic stuff done well. So we see lots of kids with neurodevelopmental conditions such as autism or ADHD, for example, where putting in place those behavioural interventions can be very challenging, but actually getting them in and done right is the thing that is most likely to improve sleep. So we help support families as best as we can to do that. And lots of that is done without using medication, but there is a role for using medication to help with those processes as we go along.
Yeah. And if you have people who are suffering with insomnia to the point where they can go for days, and I've had it in the past myself, where it just perpetuates and you find yourself extremely tired at the end of the day. You can't sleep. The day turns into morning. And it just goes on and on and on. And you do eventually fall asleep, and it's always at the wrong time.
Yeah.
And then it just becomes a vicious cycle. What can we do to get ourselves out of this?
So it's a really complex problem. And insomnia, although one of the commonest sleep disorders, is also probably one of the more complex to treat. And that's because its causes can be very multifactorial. And getting it right is, again, often about trying to get those simple things done right. When you've got into a bad habit for sleep, which is often what's ended up happening for lots of reasons, at some point you're going to have to break that habit and make new ones. And that is very similar to telling people, it's very easy to lose weight. You eat less and exercise more. And even if you rationally understand that, actually doing that can be very difficult. Telling somebody to stop smoking, really easy, and they're often very motivated to do it, but actually stopping smoking is difficult because you have to break a habit and form a new one. So for straightforward, in that no other kind of medical disease is complicating insomnia, not meaning it's simple, the solution is usually a modified version of cognitive behavioral therapy. So it's about identifying what the current habits are, the current cognitions are, breaking those down and re-establishing new ones. And there are very well-established models for doing that. And again, that is the most effective treatment strategy for most adults with insomnia. There are some great resources out there that can help to do that. So there's a web-based app called Sleepio, which is evidence-based. It's been shown in trials to be effective in improving insomnia for adults. And depending where in the UK you are, the NHS subsidises access to that. So, for example, within London, the London CCGs have agreed that anybody registered with a London GP can get free access to Sleepio and do it. It's hard work. It's really simple, but it's difficult to do. But it will guide you through that process of identifying what your current problems are with sleep, how to break those down, and how to make the changes to make things better. One of the really interesting things, though, is that our adult lab will often get people coming in saying something very similar. You know, I don't go to sleep, and when I do, I get maybe half an hour of sleep, and I've gone for days without sleep. And we bring them in to do a sleep study, and they will be in the lab overnight for 10 hours. And in the morning, they will say, yeah, I didn't sleep at all. And we will be able to say to them, well, actually, you were asleep for 7-8 hours last night. But their perception of wake and sleep becomes distorted when they have got into chronic bad sleep habits. So most people who feel like they haven't slept have probably slept more than they realize they have, but are senses become distorted in that kind of funny space in between wake and sleep.
That's quite interesting. So it's possible that, or you do see it actually, no,
Yeah,
it's
absolutely.
actually the case that people wake up in the morning or feel like they haven't slept all night, but in actual fact that they've actually had a few hours of sleep. What's the quality of that sleep?
So, I mean, that's one thing that you then start to look at. So the quality is likely to be non-refreshing. But what you can then start is you're beginning to break down their conceptions. So they've got false cognitions, if you like. You know, I did not sleep at all. And that step of being able to show them and demonstrate to them, look, actually, you were asleep, is the beginning in trying to break something down to be able to get something new in place. And that's a complicated thing to do. Relatively straightforward, but difficult to do for many people. But the process for doing that is well established. And saying Sleepio is a great way for talking people through that. And
over how long do they do this for?
Depends.
It depends on the patient.
How long does it take somebody to lose weight, or how long does it take somebody to stop smoking? It very much depends. But again, it's about getting the right approach in. And the role often of sleep physicians is not to cure insomnia, which often upsets people. Our role is really to say, look, is there a sleep disease here or something that is fundamentally affecting the quality of sleep that makes this difficult? And if there isn't, unfortunately, then our ability to cure, in inverted commas, is much more restricted. And often it's about guiding people through, giving them the tools to be able to look at their own sleep and deconstruct it and reconstruct it to get to the other side where they want to be. Small goals, break it down and do things in chunks.
You mentioned something quite interesting earlier, which I'm certainly interested in, and that's the caffeine aspect of things.
Yeah.
And I love coffee. And so
so do I.
Is it possible to have a healthy sleep pattern and still take caffeinated drinks?
Yeah, and again, this is something that's very individual. So caffeine is metabolized by an enzyme which comes in a number of varieties. And very broadly speaking, you can be a fast metabolizer of caffeine or a slow metabolizer of caffeine. So if you are a fast metabolizer of caffeine, you are likely to be able to take in more caffeine and have less of an impact on your sleep than somebody who is a slow metabolizer of caffeine. And you get that anecdotally. You will know people who, if they have, a single espresso at 10 o'clock in the morning, will say, oh my God, that's it, I can't sleep for the next day kind of thing. And there are people who are mainlining coffee all through the day and then seem to sleep relatively well at night time. We'll come back to that in a second. So there's that fundamental physiological difference, first of all. The beneficial effect of caffeine is to block something called sleep pressure. So sleep pressure is this concept that the longer you have been awake, the more you build up a need for sleep. And what caffeine effectively does is temporarily block that sleep pressure from having an effect on the brain. So when you take caffeine, you feel more alert and more awake whilst the caffeine effect lasts. The problem is it doesn't last that long, really. It wears off, and when it wears off, the sleep pressure has not gone away. It is still there exactly as it was, and it's built up in the meantime. So when it wears off, you probably end up feeling more tired than when you first took it.
Is this from a dopamine?
It's adenosine mediated.
Is it adenosine? Okay.
But what then often happens is people then take another hit of caffeine, and what most people who do that find is that the caffeine has the returns become less the more you take it. Diminishing returns, that's the phrase. So you get to the point where actually you take more and more caffeine, it has less and less positive effect, and you start to get all the negative effects of having too much caffeine. So you get jittery and short-tempered and all the rest of it. So it has a limited role in terms of its positive effect. So if you are using caffeine to address fatigue, we usually say try and take it towards the beginning of the day, don't take it from the mid-afternoon onwards, and try and be sensible about how much you take. The half-life of caffeine is about 6 hours. And even though the positive effect wears off relatively quickly, we can then usually see a negative impact on the quality of the sleep once you do get to sleep from caffeine. And it takes a long time for that to wear off. And what people usually say is, oh, I've had 6 cups of coffee and it's not having an effect on my sleep because I still get to sleep. And what's usually happening there is that those people are just so chronically sleep deprived that they are getting to sleep, but the quality of the sleep is still rubbish. The worse the quality of the sleep they get the next night, the more tired they feel the next day, so the more dependent they then get on caffeine. So again, we encourage people who are using lots of caffeine and think they have a sleep problem that they want to improve, that what they probably need to do is do the cold turkey from caffeine for 2 to 3 months, allow themselves to reboot, and then try and get into better sleep habits without it and see how things go.
I think that's probably a bigger problem than maybe we realise.
Yeah. So, and it is very variable. So different people are affected to different degrees. But the only way you know how much you're being affected is to properly go cold turkey for 2 or 3 months and then try and reevaluate from there in terms of doing it.
Does decaf drinks play a role? I know it's not uncaffeinated, it's decaffeinated.
But you'd be amazed how few people know that. So your average cup of tea or coffee probably has somewhere between 30 to 45 milligrams of caffeine. A decaffeinated mug of tea or coffee probably still has about 5 milligrams of caffeine. So if you happen to be sensitive to caffeine, then even the small amount of caffeine in decaffeinated can still be a problem. The other common culprit in that is chocolate. Chocolate has a relatively high caffeine content. And again, for people who are sensitive, the bar of chocolate before bed or the hot chocolate that theoretically, nice, warm, relaxing milk, the caffeine in that might potentially also be affecting your sleep. So you have to think about the more unusual places that caffeine lurks. So green tea, for example, herbal tea, but has just as much caffeine. Caffeine is a common cofactor in many analgesics. So, you've had a horrible day at work, you've got a stress headache, you pop 2 Anadin, and actually you've just had the equivalent of an espresso of coffee. So you need to think about all of the places where caffeine might lurk as well.
Fizzy drinks as well.
Fizzy drinks are a massive culprit, yeah. So again, a can of fizzy drink probably, again, has at least an espresso equivalent of coffee in it.
Is it really that much?
It's about 35 milligrams, and an espresso is probably about 45. But yeah, it's that order of magnitude usually.
Wow, I had no idea that much. I assumed it was just a small amount, just for so that's why people say they don't drink tea or coffee, but they have
they're getting their caffeine in other ways. Yeah, absolutely.
That's very interesting, actually. So, with regards to sleeping tablets, I have a lot of patients that will say, I need a sleeping tablet, doc? And this is more so when I was working on the wards, was more, more accustomed to being asked that question. And there were times where I was reluctant to prescribe it because I often found that the patients would become quite dependent on it and go home with it. And then when they next got admitted to hospital, found out that the GP was continuing prescribing it. And so I was quite reluctant to go down that route, knowing that it became somewhat an addiction. And I wondered what your thoughts are on it. And is there a place for sleeping tablets and Nitol and all these things?
So, caveat at the beginning, I'm a pediatrician. I haven't cared for an adult patient since 2001. So I am not the best person to be giving advice about adult sleep in detail. However, as a general principle of sleep medicine, sleeping tablets are not the answer. There is good data in adults that if you prescribe, 100 patients sleeping tablets, you will cause more harm from side effects than you probably get benefits of. So they are absolutely not a carte blanche answer to sleeping difficulties. Hospitals are an appalling place to try and sleep for lots and lots of reasons. And actually, the more difficult piece of work which needs done is we need to think about that, and we need to try and redesign both the architecture of hospitals, but also how we act at night as healthcare professionals and what the impact of that is on our patients' sleep. So we're doing a piece of work in the Children's Hospital here at the moment that is looking at exactly that. How do we improve the quality of sleep for our inpatients? Our adult hospitals have done a similar piece of work in the last few years. And again, it's all really basic, boring stuff. If you're on night shift and you've got hard floors on your wards, don't wear clumpy shoes. You don't need to have alarms and buzzers set to maximum volume. Do patients really need that medication prescribed at 3 o'clock in the morning and be woken up to get it? Do patients who are down for routine OBS and you're waking them up, do they really need that? So obviously, if patients need medications and observations that are essential to their care, then yes, that takes priority. But sleep is essential for health. We are in the anniversary of Florence Nightingale's birth this year, and there's a whole lot of celebrations going around our trust for that because she was a GSTT nurse before GSTT existed in this hospital. And she was very keen on this. She said, anything that you do after a patient has gone to bed for the night and disturbs them, the consequences of that will be far worse than just letting them sleep a lot of the time. So prioritizing sleep is something that we are really bad at doing in hospitals. And as with many things in medicine, when we don't do the hard work well, prescribing seems like a quick and easy fix, and it usually isn't. There is a role for sleeping tablets. So in adults, there is often a role for thinking about the use of sleeping tablets in short term. So the classic example of that is in grief, where people have got a very acute, definite reason why their sleep is affected, and actually giving them a period of stable sleep is likely to help with lots of things. Then short-term prescription is often very beneficial. But for the majority of people with long-standing sleeping problems, sleeping tablets will probably not be the answer. There is probably a subset for whom there is long-term benefit, but that needs to be properly thought about.
Sure. And what's the quality of sleep like with the sleeping tablets? I haven't seen the studies.
So again, it depends, and it depends what the reasons are for why the sleep was a problem in the first place.
Sure.
You can buy better quality sleep with sleeping tablets for some people that, and again, it comes back to that relationship between sleep and mental health, for example. So if you're in a bad place for whatever reason, grief is a good example of that, and the sleeping tablets buy you slightly better quality sleep, then you get a bit better sleep, which means you're a little bit better able the next day, which you then means you're better able to sleep. So it's about that kind of holistic approach to it rather than looking at it as a simplistic standalone thing.
Sure. And with we have talked a little bit about mental health side of things, and is it sometimes difficult to determine what's causing what in terms of is it the sleep deprivation causing the depression, anxiety, or vice versa?
It absolutely is. But one of the challenges, and again, we see this even in the pediatric clinic, is that often people are relatively blind to the consequences of things in the daytime. And what they present with is, I have a sleep problem. So a lot of the work of a sleep physician in a sleep clinic is often about doing that detective work to say, well, what else might be going on here? So a really, sadly, common example in the pediatric clinic is that if a child is being bullied at school, they might not talk about that. They might not tell their parents, they might not tell their teachers, they might be bullied for a long time. And you start to see that come out in other ways. So you might see their behavior start to go off in the daytime. You might see them start to develop sleep problems. And it's the sleep problems or the behavioral problems that lead to them to then coming to medical attention or that being escalated, when actually the root problem is something completely different. So there's often that bit of detective work about trying to work it out. And again, as I was saying before, though, it's regardless of what the cause and the effect are, the solution is probably going to need to involve both sides of that. You are not going to fix things by just focusing on sleep. You're going to have to do that all day, holistic picture as well.
And going on to the health worker side of things. So this is something that very much interests me. So I've just finished 3 night shifts this morning, and I'm back at work in a couple of days, less than 48 hours. What advice do you have for someone like me who's literally got finished night shifts, going on to day shifts, and trying to get back into a normal sleep pattern within a 48-hour?
So lots. And I said at the beginning, this is something that I've been working on for the last 6 or 7 years since I became a consultant. We have normalized a lot of things in providing 24 hours a day, 7 days a week cover, and we have ignored those things for a very long time. So when I'm teaching and explaining about this, both to people who are working night shifts, but also to the people who employ the people who work the night shifts, I tend to boil this down to some very basic principles. Night shifts, fundamentally, you are not evolved to be awake at nighttime. You are evolved to sleep at nighttime. And that means that when we ask somebody to work a night shift, we are asking them to do something that is profoundly unphysiological. And we don't really think about it in those terms. We just kind of go, it's something we've got to do as part of the job. But every single cell in your brain and body, particularly when you get to that real circadian low point at 3, 4 o'clock in the morning, is screaming at you that you are meant to be asleep. And it is just not possible to continue to function at the same standards as you would in the daytime, at that time at night, without at least thinking about how we compensate for that. And we just don't. It is effectively the same as working when jet lagged. When you are jet lagged, your body clock, your internal circadian drive is out of sync with the time and wherever you happen to be. And most people who've experienced jet lag, it's not a pleasant experience, and it takes a few days to realign your clock until those symptoms go away again. But when we ask somebody to work a night shift, that's exactly what we're asking them to do, to work against that body clock. Lots and lots of consequences of that. And one of the big problems with that is it means that night shifts inherently are a fatigue generating state. So you're not meant to be awake. You are fighting against that clock. You are going to get less sleep and less good quality sleep when you sleep in the daytime. So over the course of night shifts, you accumulate fatigue on top of all of that, which means certainly by the time you've got to the end of a few night shifts in a row, actually you are not really in a physiological good place whatsoever. And that has real consequences. So one of the drives that led me to start doing this work is that we still horribly regularly see doctors and nurses and other healthcare professionals who crash and die driving home after night shifts. And when the causes of that are looked into, it's often really difficult to definitively say, but these are often lone driver crashes, and the assumption is that fatigue was probably the key factor. And that is a consequence of what we ask them to do the job. And that is a huge cost. And I say these stories are horribly common.
Yeah.
We've done a lot of work within anaesthetics around this over the last few years, because a few years ago there was a tragic death of anaesthetic trainee Ronak Patel, who was doing just that, trying to drive home after a night shift. And in response to that, the association, anaesthetists Great Britain and Ireland, the Royal College of Anaesthetics, the Faculty of Intensive Care Medicine, have done a huge amount of work around what's called the Fight Fatigue campaign, about what they can do to try and put in place resources to try and help improve this. It breaks down into two very broad principles. On one level, if we are asking people to do something that is profoundly unphysiological, then there are hints and hacks and tips that somebody like me can tell somebody like you to cope better with working at night. And I can talk a little bit more of that in a second. But one of the biggest problems with that is that if that is the only focus, if we just say, do you know what, the problem is that you're just not doing things as well as you should be doing, you need to do this better and cope better, then that is the worst possible idea of what often gets called resilience. And we know that when people are under pressure, it has a huge impact in terms of stress and burnout and sick leave and all those kind of things. There is a difficult relationship with resilience. So resilience is often then seen as a bad thing. And if it's the only part of a solution, it is a bad thing. But me teaching you how to work better at night is teaching you some degree of resilient skills. So there is some role for that, but it must be balanced by systemic acknowledgement of the problem and systemic solutions. And that's the other bit of the work that we've been doing with lots of people, including the anaesthetic colleges over the last few years. The most fundamental thing about that, again, one of the things that we've normalised in an NHS that is under increasing pressure, is that if you're working a 12-hour shift and you work a shift without a break, then lots of people accept that as just normal. Whereas what we should be doing is saying, well, actually, it's not possible to sustain function performance on any shift for longer than, probably more than about 4 or 5 hours maximum, particularly a night shift. So we should be saying that breaks are absolutely essential to deliver care to the standards that our patients deserve, let alone looking after ourselves. But we've all normalized this kind of idea that, if you get a break, wow, that was a great shift, that's an unusual shift, when it should really be the other way around. And this I can literally talk about for hours, so I can focus on bits and pieces.
Please carry it, whatever you feel is relevant.
So the bit you asked first, the things that you can do. So unfortunately, the most simple and boring bit is that if you are chronically sleep deprived with poor quality sleep before you come to do night shifts, then your ability to cope with night shifts is going to be less good. So accepting that it is difficult for people working a rotating shift pattern to really optimize their quality sleep, it means you really need to put in the effort to make sure you're getting as good quality sleep as possible. And that is something that many people struggle with, let alone people on punishing rotas. If you've done that, there are then some simple things that you can do to try and get things better. So things like, so before you start your first night shift, we all tend to be a little bit more sleepy in the middle of the day. So trying to capture that and get a nap before you come in, bank a little bit of sleep before you come in. Plan how you're going to work strategically through your shift. So make sure you know when you're expected to get breaks, and barring, the multiple crash calls at the same time, being really militant about making sure that you get your breaks and that you cover your colleagues to get their breaks, which is often key to that. There are hints and tips about how to use caffeine. So we've already talked about that in the context of daytime fatigue, but at nighttime you can use caffeine to offset some of that fatigue, but acknowledging that if you take too much of it, it has a cost. So using caffeine towards the beginning of the shift. One of the things that I recommend is that you are entitled to breaks, and actually the regulations have just changed. So if you work a 13-hour shift, you're now entitled to 3 30-minute breaks during that period. If you work between over 9 hours, it's 2, but once you get to 13, it's 3. If you can use at least one of those breaks during a night shift to have a short power nap, so a 15 to 20 minute condensed light nap, most people find that offsets some of the impact of fatigue a little bit. And this is where my favorite caffeine trick comes in. Caffeine takes about 15 minutes to be metabolized. So if you take your last shot of caffeine of the night, just as you stick your head down to have a power nap, when you wake up, you get a double benefit from both the sleep, but also from the caffeine kicking in.
Sure.
So there's lots of practical hints and tips like that. I can signpost you towards some written resources that go along with this that kind of talk people through.
Please do, and I'll put the links to that in the description.
The bit about recovery. So again, most people unfortunately today are on rotas where you finish night shifts Monday morning. We expect you back at work to do a day shift on a Wednesday morning. That is probably the absolute minimum physiological time to reset your clock. So you have to be skilled at doing that. And again, this is something where there is a bit of individual variation, but I think the strategy that is most likely to work best for most people is you finish that night shift on a Monday morning, do something to decompress. So I quite like the idea of a post-night shifts team breakfast. Everybody goes, and in the old-fashioned sense of the word, you get to reflect on things that you might have done. If you're going to go and try and get good quality sleep, but worrying about the decision that you made about Mrs. Smith or Mr. Jones, then that's not great for sleep. So try and decompress with your colleagues, and a post-shift team breakfast is often quite a good way to do that. Then get yourself home. And what I usually say to do is to try and have a nap of about an hour and a half to 2 hours, which is about one sleep cycle. And what that will do is give you enough of a recharge to hopefully that you then get up, ideally before midday, then get out into the world, do as much normal activities as possible, daytime light, exercise, try and reestablish your normal daytime activities. Go to bed as close as possible to your normal bedtime, and you hopefully will still be sleep deprived enough that you'll be able to get to sleep okay. But then the absolute killer, I'm afraid, is you then need to set your alarm to get up at the normal time on the Tuesday, the next day, and be really militant about getting out of bed and not having a lie in. Because if you have a long lie, you are then going to find it difficult to get to sleep at your normal bedtime on the Tuesday night, and then you're going to have to get up at the Wednesday morning to come to work. And if you've gone to bed late, you come to bed to work sleep deprived. So it's about trying to force yourself and hard reboot yourself as quickly as possible. And that's one of the advantages. If you've got a good core sleep routine coming into night shifts, most people then find it easier to do that hard reboot back in again. But different things work for different people. So it's about knowing your own sleep pattern and applying things that work for you.
I can relate to that. So what you just said, it's the waking up the next day.
Yeah, and that's the really difficult bit.
I find that very, very hard because you have that initial, you initially wake up roughly the same time that you normally would, and you realize you don't need work, you're still tired, and then you go back to sleep, and then 4 hours later,
And then the problem is when it comes 10 o'clock, 11 o'clock, you've then just not been awake long enough to have enough natural sleep pressure to help you to get to sleep. So then you find it more difficult. And then you end up not going to bed till midnight, 1 o'clock, and then you have to get up sleep deprived the next day. And then you're starting your day shifts on the wrong foot. So it is difficult, but that's the most important thing. And the exposure to light is really important. So once you're out of bed, as much bright light exposure as possible, because what that does is tells your body clock that it's resetting back towards day mode.
Yeah, it's very reassuring listening to you say about the night shifts, because it's been in the past. It's definitely better now, at least from a personal point of view, in hospitals that I've worked recently. And, we have a place to rest and it's lovely. But in the past, I was noticing they were starting to take away on-call rooms.
Yep, absolutely.
And I was having I won't say argument, discussion with someone, and I was questioning why taking away the on-call rooms, and the argument was you're working a shift pattern, so you're paid to work your 12 hours or whatever it might be, you've been asleep during the day. And my counter-argument is that it's not the same.
Yeah,
and
absolutely.
you're there on call, you're there for emergencies, and you're there to do the best you can for those emergencies, depending on which your specialty, of course. But it's not the same as working a normal day shift.
No. So there are a few key things about what you've just said. So first of all, I think things probably are a little bit better now than they were a few years ago. There's still a lot of work to be done, but that is in large part through some quite high-level campaigns to support this. So as well as the anaesthetic colleges have done a huge amount of work on this, the BMA have also done a huge amount of work on this over the last couple of years. And one of the things they developed a few years ago was a thing called the Fatigue and Facilities Charter, which outlines a lot of the principles that we've talked about, which I think almost every trust in the country has now signed up to. And that includes things like provision for appropriate areas for rest and things like access to decent quality food and all the rest of it through the night. So the Fatigue and Facilities Charter is a really important part of that discussion about what hospitals should be doing. The idea you are paid to be awake at night, you're not paid to sleep. When somebody says that to me, fundamentally what that tells me is they do not understand that basic bit of biology that says that people at night are meant to be asleep. And the use of appropriate sleep at night, so things like short power naps, is a way to actually demonstrate that you are aware of your limitations because of biology, and you are then doing your best to offset that, to protect both yourself, but also to make sure that the care that you're delivering to your patients is the standard that we should be aspiring to. So any senior manager, any chief exec or chair who tells you that you're not paid to sleep at night, then send them in my direction, and I will very happily try and educate them about why that is a very outdated and incorrect and unsafe, fundamentally unsafe way to think about it. The problem is, though, is that the way that we work in hospitals has changed, and where a generation, 2 generations ago, the expectation may be that people could spend much more time on a night shift asleep, although we are there to provide so historically, we were there to provide emergency and essential care, but actually that the proportion of what is now acute and essential versus emergency is actually much higher now.
Yeah.
So actually there is a much higher workload at night. And I don't think we will ever get to a point where somebody would, unless they're in a specialty where they're providing just an on-call, where they would be expecting to get long periods of sleep at night. The on-call rooms, I think losing them was a shame. I think that the main reason that they were lost in most trusts, to be perfectly honest, is space. The space was needed for other things, and they've all been repurposed into other things. And we've seen, the hospital messes have gone the way of that. We're now fighting to get those back. Offices for senior staff have gone the way of that as well. And more space becomes purpose to clinical space. So I do not think we will get on-call rooms back for the majority, because they would say this is not an efficient use of hospital space. And there's a degree of truth to that. But what there is a responsibility to do is make sure that there's appropriate provision for staff to be able to get appropriate rest. And what that means is a much more responsive and not quite as good quality in many cases. So you've lost a separate room with a bed, but what now needs to be replaced is somewhere where you can get appropriate rest, including the ability to nap. And that might be making sure the mess has appropriate, and it's things like reclining chairs or camp beds, or some hospitals increasingly are looking at things like sleep pods to be able to mark out those spaces in a more space efficient way. But there needs to be an acknowledgement that even without on-call rooms, we have to have staff rest areas. And the fact that new hospitals are designed without this is a huge problem. And we're very much fighting to make that point and make sure that we build these spaces in again where we've not for a long time.
Especially in nowadays where things like burnout and mental health amongst NHS workers are becoming more rife and becoming more apparent. We're seeing the dangers of it.
Absolutely. Yeah. So burnout is a phenomenally complex topic, and the contributing factors are many and varied. But from my point of view, sleep deprivation and fatigue is absolutely one of those. Your ability to cope with the normal ups and downs of life is restricted if you are sleep deprived. And if we then create an environment that actively causes sleep deprivation and fatigue, and then throw people into a job that puts you at the extremes of human emotion and experience, there is going to be a consequence. Now, part of that is the job. We all know that when we sign up to it, that there is a lot of pressure and stress involved in it. But we should all be, open ourselves to looking at things that can help us cope better. But more importantly than that, the people who are looking at the higher levels at these, the people who are providing those services need to be looking at the systems and the support around them to make sure that everything possible is in place to allow them to work to their best in those types of circumstance. And again, that's where the idea that resilience is the only part of a solution is completely wrong. So individual resilience is a small part of a much bigger solution. And the hard truth is that we are under-resourced to provide the level of care that our patients deserve in the NHS as it stands today. One point that I make time and time again is that if every junior doctor in the country filled in an exception report every single time the contract tells them that they should when they miss a rest or a break, then the only possible conclusion I think that we would draw if people did that is that we are actually not staffed to provide care to the standards of the junior doctor contract. But for many reasons, people do not fill in exception reports. And without that data, we can't definitively make that point. I can guess at it, but I can't make it. But yeah, I just think we're in a system at the moment that's under so much pressure that it's impossible to deliver care to the standards that we would think we should be.
Yeah. It's one of the easiest things for anyone listening at who doesn't work in a hospital setting to think, why is this not reported?
Yeah.
But as a junior doctor, I can honestly say it's probably one of the most difficult things to actually fulfill. And there's been times where in the past when I've been on very, very busy rotas, there was not a single day where I would leave home at the right time, and thankfully that's a lot better now in specialty that I'm in. But it's very, very hard to almost go against the system in a way.
Yeah, so I think part of it is that, and people worry about consequences. And again, the BMA, and so one of the things that the junior doctor contract put in place is a post called the Guardian of Safe Working. And the Guardian of Safe Working is meant to be a senior medical member of a trust or hospital whose responsibility is to make sure that juniors within that hospital are supported to do things like fill in exception reports and not feel that there will be consequences. I think more subtly than that, though, the type of people who come into professions like medicine, nursing, and the allied healthcare professions tend to be the people who think that they are the least important person in the equation. And if it comes down to a decision between an individual taking their break or them continuing to provide care because they think the patient needs that, they don't want the patient to wait any longer, a lot of people defer or default to the side of doing the patient thing without thinking about the cost for themselves. If you boil that back to very basic principles, so the people that come into these types of jobs were students at one point. And at some point, hopefully, they got told that if you work for 4 hours and study without taking a rest or break, then actually you don't learn as effectively, you don't function as well. And actually, if you stop and rest and take breaks, you learn better, you remember better, you feel better, you will get more work done more efficiently, even though technically you've spent less time working, because the time that you do work will be more effectively used. And that's a concept that we all forget in hospitals. We all feel guilty if there are 5 people waiting to be seen in the ED waiting room and it's time for our break. We feel guilty about taking a break, even though if we do take the break, we will probably come back from that break and deliver care safer, more effectively, and probably more efficiently than if we hadn't taken the break. And that's the kind of thing that we need to rewire people to. So that the natural instinct is to put the patient first always. And I would flip that around and say the patient always, but not always first. Sometimes the right thing to do is to stop and look after ourselves. And actually, ultimately, the patients get better care when we do that than if we just keep flogging ourselves for 12 to 13 hours solid without a break. And that is a really difficult thing for many people to actually put into practice, which is why it has to be supported at an organisational level.
Thank you. I very much agree with that, and it's lovely to hear it from another source, especially one with your experience. So thank you very much.
You're welcome.
And just very finally, for anyone listening, is there any resources that you recommend for anyone having difficulty sleeping or wanting to find out more? Anywhere that they can find them?
So a few things. So Sleepio, if you think you have a sleep problem, Sleepio, which is, I say, available free for some people, depending where you are in the UK via the NHS, but if not, is a relatively small payment as an app, web-based thing, is evidence-based and is proven to be effective for the majority of adult sleep problems. If you're an adult with a sleep problem that doesn't help, then you need to see your own doctor and get a referral to a sleep service if appropriate. If you're interested in sleep in general, there are some brilliant books that will guide you through that. There is a book called The Nocturnal Brain by one of my adult sleep colleagues, Dr Guy Leischner, which uses, it's very like Oliver Sacks, it uses stories and patient vignettes to illustrate sleep problems and does that really effectively. And then there's a book by a guy called Matt Walker called Why We Sleep that a lot of people have read now. It's been on the bestseller list for the last couple of years. That gives a kind of an overview of the current research base for sleep and why it's so important. So they're great places to start if you just have a general interest in sleep or if you think you've got a sleep problem and some strategies about looking at it. I can link you to some specific resources if you're a healthcare professional that support you through this. So there's an article that we published a few years back that is effectively tips for healthcare workers who work shifts, so we can link you to that. And then both the BMA and the AAGBI have a lot of web-based resources for individuals and departments to think about these issues and put things in place, and they then give further links to people who might be interested in taking it further.
Dr Farquhar, thanks very much.
You're very welcome. Thank you for having me.
If you are worried about your sleep pattern or having difficulty in sleeping, please do seek advice from your healthcare professional or general practitioner. If you'd like more information, including the Sleepio app, which is a fantastic tool in helping determine your sleep pattern and offering some advice, please do check out the links in the podcast description. If you're enjoying the show, please do click subscribe or follow, and please do leave me a review. And if there is a topic that you'd like me to consider for the show, please do email me at adoctorsview@gmail.co.uk or visit me at my Instagram at adoctorsview and leave me a direct message there. As always, please look after yourselves and I'll join you again next time. I'm Dr Livios. Goodbye.